Hello, my name is Valarie Mill, and I will be presenting my Doctorate of Nursing project titled Increasing Human Papillomavirus Vaccination Rates in the Primary Care Pediatric Setting. HPV is the most common sexually transmitted disease worldwide. In the United States, it has a prevalence of around 13%, or 42.5 million people. However, HPV is rarely tested for within the male population, so this number is likely much higher. The Centers for Disease Control and Prevention, or the CDC, suggest about 85% of people will have an HPV infection at some point in their lifetime. Although not all HPV strains or infections will end up causing cancer, HPV vaccination could prevent up to 90% of cancers caused by HPV. HPV vaccination rates are lower in comparison to other adolescent vaccines, with only about 75% of teens receiving their first dose of the HPV vaccine before 17, and only about 58.5% actually completing the entire series before age 17. The consequences of under-immunized youth creates a worldwide problem with increasing cancer rates in both men and women. In this chart from the CDC, you can see that although all adolescent vaccination rates are increasing every year, HPV continually displays these lower rates. There are two notes to point out while looking at this graph. In 2011, the Advisory Committee on Immunization Practices, or ACIP, began recommending HPV vaccination for males aged 11 to 12. It also changed the dosing schedule in 2016 to eliminate the third dose for those who had received their first dose prior to age 15. I feel it is beneficial to understand the typical HPV dosing schedule. Both genders should optimally receive their first dose of the vaccine series before age 15, with the second dose of the series occurring at least 6 months after the first dose. If teens receive their first dose after age 15, they will need 3 doses to be considered up to date. This is the same for any adults who decide to get immunized for HPV later in life and are under age 45. Those aged 15 and up will receive their second dose after 2 months from their first dose, and their third and final dose at least 6 months after their first dose. The purpose of this scholarly project was to increase HPV vaccination uptake rates among teens at their well child check by providing education via email to their parents before their appointment. There were many secondary aims for this project. As previously stated, HPV affects both men and women, but disproportionately affects women due to cervical cancer. Many men do not believe they can contract or spread HPV, or that they too can also have health risks associated with infection. Along with other genital cancers, there are additional health risks such as respiratory papillomatosis in newborns and genital warts. There are enormous gaps in HPV knowledge and a desperate need to inform the public on how to prevent HPV through vaccination, including alerting patients to possible consequences of infection and the impacts that they can have on their health. In a study conducted in 2016, parents identified a lack of HPV education as the most significant barrier to vaccine uptake rates. This project aimed to overcome this barrier. There are also a lot of myths regarding HPV vaccination. Many parents feel that vaccination will increase promiscuity and earlier interest in pursuing sexual activity, or that their teen may not need the HPV vaccine because they are not sexually active currently. However, numerous studies have demonstrated that HPV vaccination does not increase an earlier interest in sexual activity. Along with this, all vaccines are intended for administration before the person encounters the pathogen. None of the HPV vaccines can treat or accelerate the clearance of any strains of current HPV infections. Vaccination at a younger age is also associated with a greater reduction in cervical cancer incidence. I wanted to highlight this incredible fact I found. One study suggested that HPV vaccination of the entire United States population of 12-year-old girls would annually prevent more than 200,000 HPV infections, 100,000 abnormal cervical cytology exams, or PAPs, and 3,300 cases of cervical cancer, as long as cervical cancer guidelines remain the same as the screening guidelines currently. And that's just the female population alone. Another barrier to vaccination seen in research is that parents did not know the vaccine series was upcoming, and they felt put on the spot to make a decision by their provider. This urgency to decide triggers uncertainties and can lead to unanswered questions and even poor communication outcomes between providers and parents. The email education piece addresses safety concerns and allows the parents and patients to discuss and decide on vaccination before visiting the pediatrician. It also allows the parents and patients to formulate any questions they may have for their provider. Another secondary aim of the project was increasing the number of clinic-wide HPV series completions. The highest indicator for HPV vaccine series completions is acceptance of that first dose. This is a great visual from the CDC that summarizes the impact of HPV-related cancers. While women are greatly affected by HPV, cervical cancer screening can also detect precancers for them. However, these procedures to treat precancers, such as colposcopies and LEEPs, are often uncomfortable and painful, contribute to higher healthcare costs, and they can also cause issues for the woman later down the road when she decides to become pregnant. However, near the bottom of the iceberg, we have all these additional cancers that are also caused by HPV, many of which affect men and women. These cancers cannot be detected with screening tools like a PAP, so they often go undetected for years until they're in later stages and become way more difficult to treat. The inclusion criteria of my project was expanded from the initial decision to only include 11-year-olds to an age range of 10 to 13-year-olds. Not only would the smaller inclusion criteria of only 11-year-olds resulted in a much smaller criteria than I needed to see if they had made a statistical difference, it also would not have matched the original goal I had to increase vaccine uptake of that first dose of the HPV series. I have the privilege of working with 7 wonderful pediatricians at the Boulder Medical Center where this study was conducted. The majority of them offer the HPV vaccine series starting at the 11-year well child check. However, one of them offers the vaccine starting at 10, and another one suggests or mentions the vaccine at 11, but doesn't really encourage it until 12-year well child check. All the pediatricians continue to encourage parents and patients to receive the first dose and the subsequent well child checks if they had declined in the past when the first dose was offered. In order to include as many patients as possible, the inclusion criteria was organized to include an age range of 10 to 13-year-olds, depending on which physician is their primary care pediatrician. There was a lot of collaboration with Boulder Medical Center's IT team for this project, and this project would not have been possible without them. So the IT team generated a weekly report of patients who met the inclusion criteria and were scheduled for their well check within the following week. The list of patients who met the inclusion criteria was organized by pediatrician based on the age they offer the vaccine, ranging from ages 10 to 13, as previously mentioned. I checked each patient chart to ensure that they had not previously received an HPV vaccine. This would be their first vaccine. They matched the age criteria again, and to ensure that the emails provided by the IT team matched both the emails that were in the chart and on the registration sheets. I then sent an individual secured email to each patient's parent's email address. After the intervention period had concluded, I performed a retrospective individual chart review and tallied all patients who received their first HPV dose. To collect reliable data, the sample size of the control group needed to match the intervention group. So another retrospective chart review was done to tally vaccine rates among patients who met the inclusion criteria, whose parents did not receive the HPV education piece. All of these results were tallied, meaning that no patient identifiers were used in collecting the results. So this is the attachment that I sent to all the parents in the intervention period. Possibly due to security constraints, the email education piece could not appear as an image when the email was opened, only as a PDF attachment. This education piece was reviewed and approved by all the pediatricians prior to implementation. Literature review for this project was a great help in deciding what I used on this education piece. Mostly, research demonstrates several reasons why parents decline the HPV vaccination series. The main reasons include concerns over safety and side effects, which is why I included an entire section on that. They also included reasons as far as uncertainties regarding the benefits of vaccination and unanswered questions regarding HPV in general. So I created the education piece in hopes of addressing common questions about the vaccine, along with addressing concerns, especially safety and side effects. The education piece highlights the importance of the vaccine, and I think it also addresses a lot of the reasons why patients should receive the first dose of the vaccine at this upcoming appointment. So for the results, so out of the 107 parents who received the email, 52 patients received their first HPV vaccine. In the control group of the same sample size of 107, 45 patients received their first HPV vaccine. So a very, very minimal increase with the intervention here. Due to smaller than anticipated sample size and the many other factors that can affect a parent's decision to vaccinate, there is little evidence to suggest the email education piece positively or negatively affected vaccination rates. So once again, these numbers demonstrate a very small difference since the email intervention was implemented. The difference between the two proportions for the Z test was only 0.065. So to reiterate, parents who were sent the email education regarding HPV vaccination did not demonstrate statistically different vaccine uptake rates when compared to parents who did not receive the email education. The achieved power of the study was 0.4226, and that is quite low, unfortunately, in strength. And that could also likely be due in part to the smaller sample size than was suggested. The most significant limitation of the project by far was the inability to determine whether the email was actually opened or whether the attachment was read before the appointment. To protect the privacy of the patients, the email was created for this project specifically, and very few members of Boulder Medical Center even had access to it. It was a very, very secure email process. Email address sender was identified simply as info@bouldermedicalcenter.com, which may have seemed vague, and perhaps parents overlooked that email as an appointment reminder or maybe spam. Read receipt feature also would not work with this email, and recipients could not reply to the email due to its required safety measures. And all of this was intended to protect patients and their identifying features of emails due to HIPAA concerns. So these security features really made it difficult to determine how reliable this educational tool really was in increasing vaccine rates. The message in the red box that you can see here on the screen is the exact message that was sent to all the parents along with the email education piece. Subject line in the emails usually read HPV vaccine information from BMC Pediatrics, and this was in order to encourage parents to hopefully open the email. As mentioned, the email education piece had to be sent as an attachment rather than just popping up as soon as the parent opened it, and this adds another step that maybe parents just failed to really do. Timeline of the emails sent in relation to when the child's appointment occurred could have still been another factor. Perhaps some patients and parents did receive the email too late and they still felt rushed and didn't feel that they really had enough time to research the vaccine the way they wanted to. There are also so many other elements that affect this study, many of which, as I have discussed, as just reasons why parents often choose to not vaccinate their children. And for example, any emails that were sent to parents who have under-immunized or completely non-immunized children, which unfortunately does occur in our practice, those parents likely didn't really want to receive that education, and the email probably did not have as much of an impact, unfortunately. Parents also often want to space out vaccinations, and the HPV vaccine is typically offered at the same time or around a similar time frame as the meningitis vaccine and the Tdap vaccination. Patients often have needle phobias. This is a big problem as well. And so when they're given a choice, they want to defer the vaccination too. Although all the pediatricians in our practice encourage and support vaccination, each pediatrician also differs in the way that they counsel their parents and their patients. And they also differ in their patient population in general. An example of this is the pediatricians who have been with the practice longer tend to see more adolescent patients in comparison to the pediatricians that are a little bit newer to the practice. They're often accepting more new patients, and so they're often seeing a lot of the newborn from the practice. So although I did try to match the control and intervention groups, there's obviously a lot of other factors here that I could not really overcome, and there's variations in the pediatrician schedules that I can't account for, considering that they often were on vacation maybe for one of the weeks, and so those adolescents that would have been on that week's schedule were seeing a different pediatrician who maybe offered it at a different time, but still within that inclusion criteria. So due to statistical results and all of these limitations, the results of this project are not generalized and would highly depend on the population and the situation in which this email education was dispersed. So just a little more discussion and kind of implications for future practice here. I would say in benefit for my project, prior to this intervention, there was no vaccine education or notifications of upcoming vaccines sent to parents before an appointment. The first time that most parents are usually aware of upcoming vaccines is during the rooming process when the nurse lets them know, hey, your child is due for the following vaccines today, what would you like to do? Which definitely kind of triggers some of those uncertainties likely that I had discussed previously in the presentation. However, studies do demonstrate a really strong correlation between vaccine acceptance rates and the introduction of upcoming vaccines. And this introduction could occur face-to-face or in another form of parental education, much like the intervention I used, which would also allow parents and their patients to formulate those questions and research and think about what they want to do with the vaccine. So parental education is also undoubtedly a factor in accepting HPV vaccination. Research also suggests that the patients themselves also can positively influence acceptance rates when they feel that they are well educated on the vaccine. And adolescent patients often feel more involved in their health when HPV vaccine education included addressing fears of vaccinations, such as side effects, and also addressing altruistic motives for vaccines like protecting future partners, along with other personal long-term health consequences of not receiving the vaccine themselves. The email education piece was designed to include information for both parents and patients. I really felt that it really did target this audience quite well. Ease of technology to disperse information also was wonderful, and the organizational support that I received from Boulder Medical Center's IT team really does prove that this vaccine education method is still beneficial. As the healthcare field changes and employs more technology, it's going to be very important to find the best way to communicate with parents and patients. Although this project may have not utilized the best method with email, it sets a precedence for patient education through technology. I feel this project could certainly expand and include notifications for parents about upcoming vaccines and links to evidence-based information. By finding new ways to disperse vaccine and other patient education, healthcare providers can improve access to essential, unbiased, and accurate patient vaccine education and improve health literacy for the population overall. Here's a complete list of my references that I utilized during this project. I appreciate your time, and I really hope you enjoyed my presentation.